just hope it plays this time. So we are in a situation where 2D ASD accounts for close to about a 1/3 of congenital heart disease seen in adults. It is the commonest Gucci, grown-up congenital heart. And in a certain subset of these patients, percutaneous devices closure can be offered as a very good alternative to surgical procedure. So this is the difference. An operator can take only a few minutes of the infinite number of 2D planes which are possible from any flow position. And this leads to an intra and inter-observer variation, and the 2D echocardiographic assessment of an ASD can lead to serious underestimation of the defect size. This is a data set which you acquire in a bi-cable view. If you look at this, so this is a bi-cable view. Which is this vein and this is which vein? What is this? SVC, and this is IVC. So this is a bi-cable view and this is a 3D set. 3D set because now you are going and defining the depth of it also. Now first step is data set acquired in bi-cable view. You acquire the data set, keep it. Next set is orient the data set anatomically. So earlier it was bi-cable. In second view, what you do is you rotate it that the SVC comes on top. So this was bi-cable. If this was SVC, this was IVC. Rotated by 90 degrees. So SVC goes on top, and when SVC goes on top, this becomes an anatomical. This is how anatomy is. SVC flows from top. So this is what we have done here. SVC on top, then atrial septum, atria, and then rotate horizontally to bring RA free wall towards the operator. Now you have to tilt it this way. So this was bi-cable, SVC went on top, turn it, RA free wall comes to me. Now if you look at this looks shabby. It looks nothing. It looks nothing and you feel that this is a wrong data set. No. Now you have to keep shaving this RA. You have to keep shaving this RA so that you start looking at the interatrial septum. So this is the third step. In ASD, what did you do for the first time? Bi-cable. Second, SVC up. Third, RA towards me. Now you start shaving it off, and the moment you shave it off, you see an opened up ASD. This opens up an in-fast view of the interatrial septum. It's a very simple thing. It is most predictable is in mitral and interatrial septum. Rest of the things can be imaginary, but this is something which is very predictable. Now, I'll show you a few examples. And here is an atrial septum defect, which is a central defect. See this? Now the important is how do you name it? Because you have to tell the operator that which side is the rim deficient, which side is the rim adequate, which side is the rim deficient, yet you can ignore it. There is an adequate rim but it won't hold. How do you do it? So you have to put a nomenclature to it. SVC is on the top, RA free wall is towards me, I have shaved it off, and I am looking at the central atrial septal defect. So this is how you put a nomenclature. So you don't give a nomenclature of superior, inferior, anterior, posterior, because what is anterior for me is not anterior for you. So you identify the structures which can be operators see on the fluoro. So if it is towards the aorta, this is known as an aortic margin. This is SVC on the top, so this is an SVC margin. This is free wall and this is IVC margin. So this is how you see it. The most ignorable deficient margin is, everybody knows. So this is an ASD with deficient retro-aortic margin, and this is very minimal, but we will very conveniently ignore it, because if these are margins which are so beautifully available to us, retro-aortic margin deficiency means nothing. Otherwise, what is the usual size of rim that you need? Aggressive people will say 3 or 4 also, but 5 is adequate. For starters, 5 to 7 is something which, so you can measure it. It's such a stenciled bottle, you can measure it, and certainly these are all larger than 5 millimeters. Now this is a device which is, in fact, this is fine. As against this, if you look at this, the retro-aortic and IVC margins both are deficient. So I would be very apprehensive of getting this device done. I would rather it be handled by the surgeon, because as against this, this is something, these are two comparative pictures which I have put so that there is no confusion in understanding. Mind you, and these are all pictures from transesophageal. None of them is from transthoracic. If you
full volume or zoom?
Full volume. You can't play too much without full volume, and these are things which you sit down and keep playing with. Within. Actually, these are all zoomed up views. So
after getting the bicable, you go the full volume, not the live 3D.
no, this is not live 3D.
When we are doing it, assessing it, or after getting a bicable view on the 2D.
So live 3D we do only when the operator is doing it. Otherwise, we'll prefer to have a full volume, sit down, relax, analyze, suggest to do or not to do. Once he says yes to do, we decide that it is yes to do. Then during the cath lab, we'll do a live 3D, because you can't crop and cut and do all those things in the cath lab. So this is yet another example which is more gross, and in fact these are multiple ASDs, and several times you will need 1 or 2 devices to close it, but if the margins are adequate, you might as well avoid surgery for these people.
Is the adhesive very fluffy?
For the little ones in the bottom, yes, but for the major one, you can close it. So ASD is something which small ASDs people can live very long life. So if there are 2 large ASDs and 1 small ASD, you might as well ignore the small one. You close the 2 large ones, or there is a 1 large one and 2 small ones, you ignore the small ones. It is something like post BMV. Everybody lives with an ASD. Post BMV, balloon mitral, everybody lives with an ASD. So here is a person who has aneurysm, and unfortunately what happens is that once you start cropping it, cutting it, if you don't cover the aneurysm part of it, you will start reading it as an ASD. Am I clear? No, I'll draw it. So this is the aneurysm. I am looking at it from this side, RA side, with SVC on the top IVC on the bottom. I am cropping it. The moment I come till here, I start reading it as an ASD. So aneurysms are something which you have to pick up on 2D. Then only analyze if you need to do something on it. And if you want to search for an ASD, search for an ASD here. Otherwise, if you crop it too much, you'll start reading it as an ASD. So this is sinus venosus type of an ASD, where are you expected to find a sinus venosus ASD? At the SVC margin. No? So if you are getting that as a SVC margin, so this is something which is a huge big ASD, which is SVC. No, this is the SVC and this is the ASD here, and this is how you have to be careful that what is the imagination. So imagination has to be governed by 2D. 3D doesn't give you a very good imagination. You have to have the anatomy defined by 2D first. And SVC are not amenable to. These are the small ones. This is what I said, that most people with these kind of ASDs will live life without a problem. And when you do a 3D, you will find that this is something which you can pick up very easily. This is the small ASD. If you look at this here, this is the one. You can see it here. And when you put the color across, these are the ones which will start showing color. It shows, but it doesn't move. It doesn't matter. So this is yet another fossa vallis aneurysm secondary to raised ASD. But here, if you look at it, this picture is very peculiar, because here in this picture, we are not looking at RA facing towards myself. It is LA RA by the side. So that's the reason you can pick up the atrial septal aneurysm wherever it is. And these are the mitral in relation to this, because mitral valve prolapse and fossa vallis aneurysms are somewhat correlated, not as much as bicuspid aortic valve, but they are. Now comes how to guide intervention. This is all like 3D. So this is, if you look at this is the wire, this is the implanted device, and this is an open device. Everybody knows how does the device work. This is something like the buttons of women wear blouse. They have a pitch button or whatever button it is called. So it is a device in which you keep pulling one end, the LA end, and you keep pushing the RA side, and it clips over each other. And this is the shape of this device. So this is the end-on view with two discs. This is not end-on, this is the edge. This is the end-on view of the disc. And this is post-implantation. Again, you see the SVC here, and this is across the fossa vallis. So this is what I just wanted to tell you, that whenever you are doing it, ASD closure, it is very useful to do it in 3D, because the residual defects can be found out very easily, the color flow can be seen, and you would be better off if you do it in 3D. 3D TEE. It prolongs the procedure for the patient's discomfort, but it overall shortens the length of the procedure.
Additional information can be gained for flimsy rims. Sometimes we find it in 2D.
So flimsy rims are missed on 3D, because thin rims are better picked up on 2D rather than 3D. 3D will pick up firm, thick rims. Flimsy ones, it misses. It can miss. So your size can be overestimated of ASD.
The micro ring is actually not seen bicable.
Sorry?
Micro ring.
Mitral valve?
Ring. the rim for, while the device is implanted, it's sufficient margin for the mitral valve to close. It does not interfere with its closure.
No. Mitral valve, you are pretty much safe all the time. Tricuspid, you are pretty much safe all the time.
No need.
IVC margin is quite clear. No? If your IVC margin is far, 5 millimeters, 7 millimeters, you are pretty much safe.
When you see thin rim in 2D transistors are very low, sometimes you see the edge of the rim. If we in real time we take the image, you can see the entire thickness of the rim. Sometimes, even though in 2D the rim looks like thin and floppy, the amount of the tissue is spread out.
So, if you can see the thin unfast of the floppy rim, it's something like if you can see it across this, you can measure the thickness too. I will not disagree with you. Okay, Nara, please. Lunch time for the boys or no? Ready? Shall we declare lunch for you? Thank you all. And I'll make move, but
We all